We now go on to Dr. Prasanna Venkatesh, who is again a medical consultant from Mahatma Eye Hospital, based at Trichy, a very, very innovative and pretty dynamic young guy he is. He's not just a cataract surgeon, also does glaucoma surgery and is a lot into research. And he's going to be presenting his video.
Thank you, ma'am, for the kind introduction, and thank you for this opportunity. Is my screen visible, ma'am?
Yes.
Yeah, so the case for discussion today is an Argentinian flag sign, which is also triquetral in nature, not 2 but 3. And also the novice surgeon pulled out the cystitome, causing a damaged side port as well. So this is the case for discussion, and to go back and to start the video. So here we go as to how there are so many ifs and buts. So this is one particular way in which I ended up managing this patient. So the post triquetral Argentinian flag sign in an intumescent mature cataract. Of Argentinian flag sign in an intumescent mature cataract. This sign was first described by Daniel Mario Perun in 2000, where one can appreciate two vectoral forces acting opposite in direction radially once the nick is made with a cystitome, visually depicting an Argentinian flag sign. In the case for presentation, once the nick was made, not 2 but 3 vectoral forces, that is triquetral forces, acted, causing 3 radial tears up to the equator. In this surgical case, there were 3 anterior capsule radial flap tears along with an etiogenic corneal tear at the side port. Once the nick was made, there was an inverse Y-shaped tear starting to propagate equatorially, and due to sudden withdrawal of the cystitome outside the anterior chamber as a shock response by the novice surgeon, an etiogenic corneal tear was made. So, the complication of Argentinian flag sign with a damaged side port was now on my plate to manage. I wanted to secure the side port corneal tear to have a steady anterior chamber during phaco maneuvers. Any fluctuation in the anterior chamber will only further propagate the equatorial tears into the posterior capsule. Slow motion phacoemulsification was proceeded to minimize the stress on the zonules. This is a fast-forwarded video of stop and chop phaco with parameters comprising vacuum of 400 millimeters of mercury, aspiration flow rate of 26 ml per minute, and the bottle height was 80 centimeters. Nucleus management was done within the bag. Quadrant was also emulsified within the bag with a few quadrants emulsified in the supracapsular plate. Quadrant removal was also managed meticulously with the reduction of phaco parameters. Another paracentesis was placed for comfort of cortex aspiration. Mindful cortex aspiration was the key without capturing the remnant anterior lens capsule. There is a guided animation on the bottom left provided to depict the creation of a circular edge for one apex of the anterior capsular flap remnant followed by residual cortex aspiration. The idea was to try and create a circular axis with the 3 triangular flaps so that IOL can be placed in the bag. The remaining 2 triangular capsule flaps was also nicked with microaxis scissors and was converted into a circular edge with a microaxis forceps. Circularity was tried keeping in mind that the surface of the anterior lens capsule would adequately be able to cover the optic of the IOL. At the end, we had a circular axis with 3 radial tears. The side port was reinforced with 10-0 nylon to prevent inadvertent leak from the anterior chamber. Then, a 3-piece sensor lens was placed in the bag. The most important point for IOL placement here was the optics of the IOL were consciously placed away from the 3 radial tears. This animation module reveals the mental mapping strategy and how the optics were placed away from the equatorial tears. This is the post-op 1 month and 1 year picture, respectively, revealing that the IOL was well centered in the bag with a good overriding circular axis over the optic with best corrected visual acuity of 6/6 and a happy patient. Thank you.
Thank you, Prasanna. That was a wonderful depiction of the video, and you just covered everything. There's hardly anything left for discussion, and truly proud of you. My thoughts on this, and I'm sure I would want one of our expert panel to tell. I think when you have these multi-directional tears, that itself sort of prevents a possibility of a wraparound tear. I think something like in our CCs, when we used to do a can opener, we never used to get a complete wraparound tear because there are multiple areas of relaxing incisions which happen, is one thought I have. And but of course, I feel that you can never be sure that the haptic is going to be in the bag. It could be in the sulcus too. So, any of you, Dr. Sanjay, Dr. Arun,
So
any?
I would really agree that that was a wonderful surgery. But the one thing which I would have done beforehand was making the rexus more circular before proceeding for nucleotomy. So I would have tried the remaining rexus to make it more circular, and then would have proceeded with nucleotomy. All the steps he has shown wonderfully well.
True, quite valid. That is
And
also
then the pupil started
wonderful
coming down.
surgery.
yes.
Wonderful surgery, but I think I would have used some Mediatics intracameral to have a better view. But wonderful surgery. We would have definitely used some Mediatic intracameral.
Sir, hindsight, I have
On
to
a
talk.
safer side.
The table, I was also quite anxious, so there were some shortcomings. I do agree, sir.
Yeah.
So my one
Anything to
thought
add?
was that why didn't we close the tear of the cornea before doing the rexus? Why was the chamber leaking when we entered the anterior chamber? You put a suture later. Once you are done, you have got a 3-tier happening.
No, I think when he started the case, he put one suture. He put the reinforcing suture in the end.
The suture came after the tears.
But coming out, the tear happened with the
Yes,
cystitome.
cystitome caused bad, sir.
The cystitome tore the
flap, that area. So it was an accidental thing.
accidental.
Yeah, Prasanna, very nicely done, Shirley. I have only one comment to make.
Yes.
Yes, sir.
Yeah, I think you used the methyl cellulose as a viscoelastic. Once, did you use 2% methyl cellulose? Because as you, after forming the chamber, as you came out, it was leaking out. So, and your anterior surface of the crystalline lens was convex anteriorly. So one of the, we have published a series also with the, not a single case of Argentina flat sign. And in your case, as we could see, there are 4 types of white cataracts. I won't go into detail. You can read the paper by Dr. Tityal. He has given even OCT classification. So even in your case, once you made a neck, there was no egress of fluid. So these are the most difficult cases to tackle because the intralenticular pressure doesn't give away or you can't aspirate anything. And above that, if you are using methyl cellulose, which is leaking all the time, even when you are doing a rexis, it leads to a shallowing of anterior chamber. So I always tell all my residents to use a high viscosity viscoelastic. And our idea is to equalize the pressure inside the anterior chamber and inside the lens, crystalline lens, so that there is, and make the anterior surface of the capsule either flat or scaphoid so that we can do the rexis easily. Otherwise, very nicely managed case of.
Should we, thank you very